Dr. Raz and I usually agree on things, but not in this episode. We're discussing breast cancer in young women. These are the women who are under 40 years old, women who have been told they are too young to have a routine mammogram, the same women who are eventually diagnosed with breast cancer. And many times that is at a later stage. So, is the incidence of breast cancer in younger women increasing or not? Our lead radiologist, Dr. Raz, agrees that there may be an increase, and it might be a trend. I insist it is, and it's an alarming trend. While I want women to be able to have a screening mammogram at any age, Dr. Raz doubts that changing the recommended age for starting mammograms will make a difference. However, he does have another solution, and you'll hear it today on Let's Talk About Your Breast. When you subscribe to our show, you help us grow. Someone you know may need to hear this story, so please share with your family and friends and consider supporting our mission at therose.org. Let's Talk About Your Breast, a different kind of podcast presented to you by The Rose, a breast center of excellence and a Texas treasure. You're going to hear frank discussions about tough topics. And you're going to learn why knowing about your breast could save your life. Dr. Raz and I are talking about, has cancer increased in younger women? I say we're seeing more here at The Rose.
Yeah, we are seeing more.
Okay. But he says that that's not incidence, that there's a whole other formula to ever coming up with this stuff.
Yeah.
Explain that part to us.
Well, incidence generally refers to the fact that how many cancers we're catching.
Okay.
And, obviously incidence has increased. There's a basal rate of increase of incidence every year for breast cancer, whether you're over 40 or under 40.
Okay.
So it's a dual-edged thing where the increase in incidence is because our screening methodologies have been better. And then there's new, you do great outreach here at Rose and all these other centers throughout the U.S. So more women are screening, hence we're catching more cancer. The question remains, has there been an increased basal rate of cancer itself, even if we don't screen? That's a difficult question to answer. However, we do know that the incidence of cancer in younger women under 40 has been increasing around 1%. So again, the question is whether are they more
but
conscious about it?
We're not screening. We're not screening.
Right, we're not
those
screening.
Women. Okay.
But they may know about it, and then they do self-breast exam when they come in, and then we find masses, and those turn out to be cancer, if that makes sense.
Okay, so we're never going to get the recommendations changed based on scientific evidence, is what you're saying.
Correct. Like the age, because it's a risk-reward thing. So if you reduce the age, let's say from 40 to 35, right, for screening.
Okay.
What will end up happening is we'll have way more false positives, meaning we'll biopsy a whole bunch and then we'll catch cancer. So remember, screening is a national program. So you have to get through a lot of red tape. This is not my recommendation.
I know.
I would rather so you'll catch more cancers.
Yes.
Now, for that matter, we screen once a year, right? Mm-hmm. There have been studies that show if you screen twice a year, you catch more cancer. Exactly.
Really?
Yes. So there are studies I don't know the name of them, but I know of them. They're good studies from reputable academic centers that, if you do screening twice a year, you catch more cancers. But again, it's a risk-reward thing. How much burden on healthcare would there be if we do that?
Until it's your life.
You're absolutely correct. Until it's your life, yes.
Okay. So if you had your way, what do you think would be the better way to screen?
So the general screening guidelines that we start at 40, these studies were made way back then. And, it's the subgroups weren't as defined, United States.
So explain what you said about these studies were all done on primarily white women.
That's correct.
Who were insured.
Yes.
Who had access
compliant
to healthcare.
To screening. Yes, compliant to screening. So all of this really makes it difficult. And there's no great way to come up with an age, unfortunately. But this is the best we can come up with. But ideally what you do is, and this is how you catch cancer under 40. And again, remember, we talked about it, that the incidence has increased. Now, whether that's because women are more conscious or there's something wrong and we're all getting more cancer, it's difficult to know.
Okay.
But let's just assume there's something happening where a lot of younger women are getting breast cancer. The risk factors are many. Many could be, early menarche, or you didn't have kids, or obviously family history or genetics, but these other things that I'm saying, breastfeeding, not breastfeeding, null parity, meaning you didn't have kids. Right. All of these are minor risk factors for developing breast cancer. What I'm trying to get to is, if there is increased risk due to various factors that we don't know yet, how do we catch it? Well, the thing is, there are subgroups within women. So whether your socioeconomic status, that's actually a subgroup. Then race, right? So we know for a fact that women that are under 40 who are Black women tend to get larger cancers if they were to get it, more aggressive cancers, and triple negative breast cancer, which has poorer prognosis. Right. So that's not as well studied. So this is the thing, like at the primary care level, when a physician speaks with a woman, there has to be an easier tool. Like here at the Rose, what do we have? We have Amanda, we have a nurse practitioner, and they go through, and she has excellent tools. She has Tyre-Kruzik model and Gale model. These are just models that risk stratify a woman, or whether you're high risk or not.
Right.
At a primary care, do these primary cares have that sort of tool? I don't think so. No. It's not very easy. I don't expect primary care physicians to know all these nuances of breast imaging and breast risk stratification. But if on a national basis, let's say we can come up with more nuanced under 40 risk stratification model of some sort, which then filters these women that, hey, you are actually higher risk than an average American woman risk, which average American woman risk is 1 in 8, then that would really help catch cancers early.
Okay, so what you're saying is, if we had true high-risk screening.
Correct.
That could be applied population-wide.
Correct.
Then we would be able to say this subset of women needs to start at age 30.
Earlier, yes, earlier. Earlier screening or different methodology. That's all science. We can all study that. Or whether we start with ultrasound, mammogram, or MRI. Ideally, it would be MRI for higher risk women. But yes, in a easier way to risk stratify women at an early age, so then we can say, hey, you can start early, would actually yield benefit.
So what would speed up that process?
Well, loaded question.
I know. What would speed it up?
So again,
look how long we've been dealing with age 40. Then it went to age 50. Now it's back to age 40.
And it was biennial. Then it's not biennial. Every other year.
Every other year.
Then and 1 year, every year. So really, it's USPSTF and the Surgeon General, everything. It's there has to be consensus on that level. Honestly.
Why?
Well, because they make the standard rules. They make all these rules that, when should we screen, and every insurance provider follows it. And
I know that. But what I'm saying is, why? Why can't a woman just say, I want to have a mammogram?
Yeah, they can. We see plenty of women that are at 30 that come in. But again, it's a matter of education, right? Right. And this also feeds into incidence, as you said.
Right.
A lot of women are doing that now.
Only because they have awareness.
Correct.
Or they become aware that they actually have a problem going on.
Yes.
Or what's mother's family history or...
So family history, and again, a lot of this is just awareness in general. People, women listening to your podcast, see? So that's all of this helps.
Yes. But at the end of the day, she's still going to need a physician order.
That's correct.
Whether she's insured or uninsured, she's still going to need someone with a medical degree to say you need a mammogram. She can't just decide that.
No. And that's where the whole risk stratification and a physician saying, hey, you're a higher risk, go do mammogram comes in. How do we implement that? Difficult to do. Again, it comes from higher levels. All these societies then have to come up with their guidelines and send it to their physician. And that's how we do things, right? So like Society of Breast Imaging, these are all of us. ACOG is American College of Oncology and Gynecology. So there's a Society for Family Practice Physicians and also internal medicine. And all that gets filtered really through USPSTF and Surgeon General and stuff. So what I'm trying to get to isn't, I'm not trying to be negative. I'm just trying to come up with practical solutions. And that's, from our local level and the community level, what you're doing in podcasts. And I talk with primary care physicians all the time, and I'm educating them. that's also part of the reason that we see, decent amount of younger women under 40 with complaints, obviously. Mm-hmm. But I mean, yes, if every breast imager went out there and started doing this, that would be helpful on a community level, on a local level.
But it really takes policy.
Yes, it does.
No matter what.
Because nationally, that's how we do it, right? Start at 40. Who decides that? ACR does. American College of Radiology, right? USPSTF does.
Yeah. So. And the insurance control it.
Correct.
And
they look at the national policy.
Right.
So.
All right. So what other great news do you have for us today as we start out 2025?
Well, the great news from the Rose perspective, I could tell you is, we're doing a lot more MRI.
Uh-huh.
So the MR is firing on all cylinders right now, and I'm reading at least 2-3 every week. And we're getting to good MRIs, good problem solving. Caught a couple of cancer in younger women that way for high risk women, and the other great news would be, there have been recent papers that are coming up with contrast-enhanced tomography, right? So it's something that we're also working on at Rose, a few months away, but that is showing excellent promise. So something that we look at is called cancer detection rate. And cancer detection rate on this new modality is up to par with almost MRI. So lots of centers have started aggressively doing it. I just speaking with my colleague at Baylor, they just started a month ago. So which is Smith Clinic, Baylor. And they're getting excellent results. They're starting, keeping documentation of all of this. So that would really help. And we were just tying it back to younger women. And if you're high-risk women, this would really be an excellent study. Because remember, the problem with MRI is compliance. And this would completely solve it.
So what is contrast-enhanced mammography?
Right. So contrast-enhanced mammography, we all know what mammography is. So specifically, it's not even mammography, it's tomography. So 3D mammogram.
Okay.
But with contrast-enhanced mammography, we inject contrast, an iodine-based contrast.
Very much like
when you go to get a CT.
Right.
CT abdomen, pelvis, if you're getting CT brain.
Yeah.
Or if you're even getting MRI, they inject contrast. And the goal of contrast is, it's easy layman terms would be if there's cancer, it would enhance. It will turn white versus tissue would not turn white, right? Okay. Color-wise, if you're speaking. It will take up color. This is the color. Iodine or contrast is the color. So then it's very easy to pick up subtle cancers. A lot of times cancer hides, especially, again, in younger women. Dense breast. Dense breast, you can hide many things, which is why we were saying, this new stipulation that we have to talk about breast density in all of our letters is because breast density, unfortunately, is an independent risk factor of breast cancer.
Okay, but remember the USPSTF.
Right. So
tell me.
Yeah, so that
they didn't approve it as a supplemental study as needing that.
Not yet. But this is how change happens, Dorothy. It starts like this. I'm being honest. It starts like this. And a lot of these women, few will get this letter and then they'll go do ultrasound and will catch something. And then this is how it works. I mean, unfortunately, it's a slow process. This is what medicine is in general. It's a slow tanker. This is not a tech company like overnight we're making new tools. And then there's a CEO. It's just a slow thing, takes a while. But these are all encouraging things. Sending that letter, that's actually an exciting development in and of itself.
It is, yes.
Because we're doing more ultrasound, we already proved that, hey, if dense breasted women come in and I do mammogram and ultrasound, if I just do mammogram, I catch cancer in 3 out of 1,000. If I add ultrasound, I catch 5 out of 1,000. I'm catching 2 extra cancer. And again, what did you just say? Unless it's your life.
Unless it's your life, yeah.
Yeah, so then out of those 2 women, they for sure will know that, hey, without ultrasound, it wouldn't have been caught.
Right.
So again, kind of getting off topic, but that contrast-enhanced mammography just adds to this detection rate.
It's in between there almost.
That's correct.
It's another one, yeah.
Correct. It's very sensitive, and cancer detection rate is as good as MRI. Remember, MRI is better than ultrasound. Impressive. It's almost as good as MRI. Well, then this will become the gold standard eventually. Again, takes some time. Studies need to come. Again, you're right. USPSTF, it gets drilled into their brain that it is beneficial. It takes them a few years.
It may take them a lot more years before all of this happens.
I'll send them a link to your podcast.
Okay, that's fine. Because I feel very strongly that we just need a lot better ways to take care of women.
Yeah, I agree with you.
And I know it's because more women come in with a problem. I know that. But my gosh, the difference in our population, the uninsured and the insured, we diagnose the same number every year.
Yes.
That's just amazing to me. And often you do see more pathology here than you have before, right?
That's correct, yeah.
And explain what that means.
So, the patient population that comes through a screening program, whether we are Rose and any other academic, tends to be a little different because it's, related to socioeconomic status, your age. So the pathology that comes in here, we take care of so many uninsured women here, tends to be, cancer that could be a little bit later stage, a little bit aggressive, and sometimes just exotic. Just the other day, there was like a myxoid cancer that I had. Really? And so it tends to be non-geographic, right? A lot of, patients do coming from South America here. So the cancer morphology is a bit different. So we tend to see a little bit of different pathology in, let's say, a patient that goes to Methodist would, if you will. So, yeah, that's what it really means.
Yeah. And because of that, it's more important for us to get them on into treatment because some of these are very aggressive.
No, some are very aggressive, especially, and I'm completely with you. Like, it's an open question, especially women under 40. What to do, how to actually do.
I knew you were with me on that.
Yes.
I just know we've got to do something different.
Correct.
For that.
And this is a fact, and even USPSTF can't deny this, that they just get more aggressive cancers, which will make sense that, because breast cancer is supposed to be an older woman's disease, so if you get it at a younger age, something's wrong.
Right.
So it tends to be germline mutation, meaning some genetic mutation or how you're born, and then these cancers just tend to be very aggressive, so you got to move in fast.
Right. And I know this is another point that we don't always agree on, but we have seen so many pregnant, or just had babies, or babies that are 5 years old or younger.
Yes, peripartum.
So isn't it time for us to do a little more awareness on that? So
peripartum cancer is often missed, unfortunately, and it's missed because the breast that, again, there's two organs that are the most sensitive to estrogen and changes a lot in a woman. And this is interesting. A lot of women, sometimes I tell patients this too. If I were to do biopsy on a breast every single day, let's say I pick a woman to start biopsying the tissue, day 1, 2, 3, 4, all 28 days, okay? And look under a microscope, the breast will look different every day. It's kind of like a uterus. So what does uterus go through? It's preparing for pregnancy every month in a woman, every right? Month, and you don't get pregnant, you get the period. And then cycle repeats. So the uterine lining changes every day because it's under the influence of estrogen and progesterone. Well, then same thing happens to breast. These are the two most sensitive organs to cycles, right, that a woman goes through. Where am I getting to? Well, at pregnancy, an estrogen is like 10x than a normal woman would. Why? Because it's maintaining the pregnancy. Right?
Okay.
Now, so the breast looks very different. It's very engorged. It's preparing for lactation, all of that. So you feel lots of lumps and bumps. Well, then how would you know which lump is good or which lump is not? So a lot of times what ends up happening in primary care just does their exam, and then they're like, well, it looks like just like a pregnant breast or, lactating breast, and they kind of let it go. And unfortunately, that's exactly where cancer, and remember, cancer loves estrogen, majority do ER-positive cancers. It's like a fat kid with cake, nom, 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 and it increases in size explosively. Remember, in pregnancy, you have 10x the estrogen.
Right.
So then you're explosively growing mass, and then it gets missed. The woman's already busy, and this is where it comes in. We need to take better care of women. Why? Because she's already working a job, pregnant, taking care of. She's like, it's kids. Probably nothing. And then my doctor said it was nothing, the primary care. And then now, well, lo and behold, this like an aggressive grade 3, stage 2, 3 cancer. And it was completely missed because of what the situation I explained. And this happens all the time.
So it's important for a woman to say, no, I think this is different.
That is correct. And that's majority of the peripartum cancers that I've caught, where a woman comes like, no, this feels different. Unfortunately, and it's almost always, it's very sad. It makes me sad because a lot of these women are in their 30s, having their second kid or just had one kid. And so, yeah, we can definitely talk a lot about this on the next podcast, and because the cancer and the way peripartum breast should be imaged, and it's a whole different topic.
Oh, well, good.
And a very sensitive
Well, we agree
topic.
on something here that we can talk about. All right, you're on. I'll bring you back, and we'll talk just about what happens when a woman's pregnant.
Yes.
Or even the years afterwards.
That's correct.
Yes.
Yeah, peripartum, plus or minus around childbirth.
Okay.
Yeah.
So,
The breast is different, the pathology is different, the physiology is different than in a regular woman. Yeah.
Oh, good. And you can get us maybe some images so we can see it.
Yes, for sure.
Okay.
I have lots.
Okay. Well, then you're on. We'll have you back, Dr. Raz. Thank you so much for today.
Pleasure is all mine. Thank you for having me.
Thank you for joining us today on Let's Talk About Your Breasts. This podcast is produced by Speak Podcasting and brought to you by The Rose. Visit therose.org to learn more about our organization. Subscribe to our podcast, share episodes with friends, and join the conversation on social media using hashtag Let's Talk About Your Breasts. We welcome your feedback and suggestions. Consider supporting The Rose. Your gift can make the difference to a person in need. And remember, self-care is not selfish. It's essential.